So the case I'm presenting today is a 69-year-old woman with advanced renal cell carcinoma. She originally presented with about a 2-month history of fatigue, lower back pain, and some unintentional weight loss. Um, Her only relevant past medical history was diabetes, which was medically controlled. On physical exam, she had flank pain and some lower back discomfort with on palpation. Clinical workup with the CT chest abdomen pelvis demonstrated a right-sided 7.9 centimeter renal mass, some slightly enlarged para-aortic lymph nodes. Percutaneous biopsy was done, which confirmed clear cell renal cell carcinoma. Given her stage of disease, she underwent a right total nephrectomy. Overall, the surgery was well tolerated and was followed with serial imaging at 3, 9, 12, and 24 months, which was all unremarkable. However, she subsequently developed stage 4 disease with multifocal disease in her lungs. At that time, her labs were all within normal limits. She remained ECOG 0, and was felt to be good risk by IMDC and MSKCC risk. She was then started on pazopanib, which was well tolerated, and she achieved a partial response. However, 2 years after she was on the pazopanib, she suffered progression of disease with some increasing lung nodules, the largest being 30 millimeters. After which, the combination of lenvatinib, 18 milligrams by mouth every day, and everolimus, 5 milligrams by mouth every day, was started. The first set of imaging at 8 weeks showed a 33% reduction in the baseline from the largest lung lesion, coming to be about 20 millimeters. At about 24 months, at week 24 of treatment, there was again about a total of a 40% reduction in the baseline largest lung lesion, down to about 18 millimeters. The other lung nodules that were there were also decreased in size. At 6 months, she continued to have stable disease, and about 12 months, unfortunately, a CT showed 2 new liver nodules. Going over some initial impressions I have of the case, this is a fairly typical time course for a patient who developed metastatic renal cell carcinoma. The initial management is often of localized disease, which the primary therapy at that time would be surgical resection or some sort of local therapy. Most patients, who undergo this type of therapy don't typically undergo any type of adjuvant therapy and are followed with serial imaging. Unfortunately, a good portion of these patients, especially those that have lymph node metastases or stage 3 disease, ultimately do develop metastatic disease. Metastatic disease with the most common site being the lungs, which is where this patient ended up presenting. When we had the initial management, when we saw this patient initially, she continued to be good risk, kind of given her long duration of being disease-free with normal labs and also good performance status. And then, from a timing standpoint, if you think about historically where they were treated, pazopanib would be a very reasonable first-line agent, which she had a good response to a single agent TKI, and subsequently developed increasing metastatic lesions in which she was started on second-line therapy.